Question number 27. A 45-year-old man with a leaking porcine aortic valve prosthesis has a fever and staphylococcal bacteremia. Whereas the initial ECG was unremarkable, after 3 days in hospital on appropriate intravenous antibiotics, the ECG now shows first-degree heart block. Which one of the following is the most likely explanation for the ECG changes? Digitalis toxicity, septal abscess, antibiotic reaction, worsening aortic incompetence, aortic valve leaflet vegetation. 45-year-old man with a leaking porcine aortic valve prosthesis has a fever and bacteremia. Initially, he was given the antibiotics, IV antibiotics. At that time, ECG was normal. After giving antibiotics, patient has a then again ECG was taken, which shows the first degree heart block. The the essence of this question is the recognition of a new onset rhythm disturbance representing endocarditis with valve ring or septal abscess formation in a patient at a high risk for endocarditis. This is a well recognized and much feared complication. So option B, which is septal abscess, that is correct. The anatomical proximity of the aortic valve ring structure to the SA node and conducting system make this dreaded complication an indication for valvular surgery. Digital toxicity is associated with all 3 degrees of heart block, but there is no indication in the stem that the patient is on digoxin. AV block and AV dissociation toxic levels of digitalis can result in any degree of AV heart block because digitalis slow conduction through the AV junction. Antibiotic reaction is incorrect, as such an adverse drug reaction is usually accompanied by fever, rash, and occasionally peripheral eosinophilia, and antibiotics are not known to be causes of a first-degree heart block. To consider this development due to an antibiotic reaction is potentially disastrous, as it will lead to a change in the antibiotic therapy away from fluoxetine or the beta-lactam class altogether. Any antibiotic other than flucloxacillin for stiff prosthetic valve endocarditis with septal abscess would represent inferior therapy. Worsening aortic incompetence may well develop in this setting. However, a failure in a valvular function will not lead to the disruption of normal rhythm in the period of a few days. The presence of vegetation will not lead to erosion and rhythm disruption in this time period outlined. So this first degree heart block is because of this septal abscess. So option B is correct. A 20-year-old woman present with her hypertension. She has a previous history of enuresis and febrile episodes in childhood. Which one of the following is the most likely diagnosis from this history? So history is very short. 20 years woman, hypertension. She has a previous history of enuresis and febrile episodes in childhood. Mostly diagnosis from this history. Options are chronic glomerulonephritis, reflux nephropathy, essential hypertension, polycystic disease of the kidneys, analgesic nephropathy. So the reflux nephropathy is one of the most common causes of hypertension and chronic renal impairment in young adults. There may be a characteristic history of enuresis and recurrent UTI with fever in early childhood. So option B is correct, which is reflux nephropathy. Recurring fevers may not be diagnosed as a UTI per se, hence it is important to inquire about febrile episodes during childhood in patients at risk. Vesico-ureteric reflux is a reflux of urine from the bladder into the ureter Reflux may extend up to and involve the pelvic ileal system and into the renal parenchyma. VUR is a condition which commences in utero and may lead to the renal scarring. It's also a predisposing factor to recurrent UTI. These scars form during very early childhood and mostly by the end of the first year of life. VUR tends to decrease as the child grows and is rarely demonstrable in an adult with a small scarring kidneys from childhood VUR. When scarring has occurred, destruction usually continues despite the absence of recurrent infection. Hypertension invariably associated with proteinuria as one of the most important consequences of reflux nephropathy, reflecting the development of a form of secondary glomerulosclerosis. The illustration shows gross VUR demonstrated by micturating cystogram in regard to a choice imaging in a patients with urinary symptoms. Previously, the IVP was the principal radiological technique used in evaluating the patient with possible renal disease. It provides detailed information concerning skeletal anatomy and the size and shape of the kidneys and is extremely useful in detecting renal stones. However, the IVP is currently much less popular since it requires the administration of contrast, and other techniques such as ultrasonography frequently provide similar or more detailed information. Nevertheless, IVP can still be a valuable technique in the evaluation and diagnosis of certain structural disorders such as a medullary sponge kidney and papillary necrosis. The IVP also has a high sensitivity and specificity for the detection of stones and provides data on the degree of obstruction. However, non-contrast enhanced helical CT scanning is the gold standard for the radiological diagnosis of renal stone disease. A young adult with hypertension may have underlying chronic glomerulonephritis, which may present de novo as hypertension associated with the proteinuria and or hematuria with impairment of renal function. There may be a past history of childhood nephritis associated with hematuria and proteinuria, usually following a febrile illness such as a post-streptococcal or post-viral glomerulonephritis. Chronic glomerulonephritis can be secondary to a systemic disease, but is more commonly idiopathic. However, enuresis and recurrent febrile episodes in childhood are not a typical manifestation of glomerulonephritis. Other options were hypertension, polycystic disease of the kidney, analgesic nephropathy. So the correct answer is the reflux nephropathy. Here is the reflux nephropathy on micturating cystogram.